So we're talking about emboli detection. Transcranial monitoring is a helpful extension in Doppler sonography. This method allows the recording of the flow velocity, of changes in the flow velocity, and also of the characteristic profile of the Doppler spectra curve over a longer period. It can therefore provide the user with valuable information. Constant industry advantages and further developments as a result of evolving medical finding means monitoring today compromises additional valuable diagnostic tools, which goes far beyond simple control monitoring. Two of the available DWL monitoring modules we will present today. I would like to start with the emboli detection, since it's becoming more and more important due to its high information value in the field of risk analysis with regards to stroke diagnostic and prevention. When we're doing TCD, we are using a certain insonation frequency. We are insonating the artery, looking for moving objects. In our case, we are looking for the velocity of the blood cells. And then when sending in ultrasound, it will be hit by blood cells. And then part of the ultrasound will be reflected to the probe and then processed by the Doppler system. So the blood cells we are looking on reflects a certain energy level. That can be measured with our TCD system. Depending on the material that ultrasound hits or where ultrasound goes through, we have different reflection energy. So if ultrasound goes through heterogeneous tissue, only part of it will be reflected, and the rest of the Doppler beam is continuous traveling till it gets reflected again, and the remaining beam is then continuous traveling till it gets reflected again, and so on. So this is the process if ultrasound goes through heterogeneous tissue. And depending on the material means as more solid, as less energy will be reflected. And if the material becomes more solid, more stiff, then the reflection energy is much higher. So in comparison from heterogeneous tissue to, for instance, a more solid particle like a calcified plaque, then we will face that the reflected energy of ultrasound will be much higher. If ultrasound hits air, as you know, there is a complete reflection of the ultrasound. So this is a limitation, and so we have a massive reflection of ultrasound, means it's a scattering. So looking back to our medical case, so we have here the artery, we have the blood cells, we have our insonation frequency, and we know the noise level, what we call now noise level of the blood cells, with a, well, not so big energy that is reflected back to the Doppler probe. And then it can happen that we get a little higher energy back. For instance, here we have the example of a more calcified one. And even if this is the same size than a blood cell, it will give us a higher reflection back than the single blood cells. And then here we have the example of a blood tromp, and since this is also heterogeneous tissue, it might give us a little more energy back or intensity back than the single blood cells, but due to its size. So probably this is 10 times bigger than the calcified one. It will still be less reflection here in comparison to the more stiff material from this, let's say, calcified plug. So the typical situation in TCD, we have in our Doppler system, we use the 2 megahertz to insonate the circle of Willis, going here temporal, to insonate the MCA, and we get our Doppler spectra. With the FFT, we are measuring the velocity profile of the single blood cells, and we can hear the noise level of the single blood cells within the heart cardiac cycle. So this is the end diastole. Here we have the systolic upstroke. And so within now we can see that there is a red spot, which is probably caused by an embolus that's traveling through the MCA, down the MCA, in this case towards the probe. And so this will appear because with a higher energy level, with a higher reflection intensity, with a red spot in comparison to the surrounding blood cells. If we would be able to hear it now, then we would hear that this sounds completely different than the noise level of the blood cells. So we hear a typical sound like a click or blick, something like this. And this is something that will clearly identify our embolus as to be an embolus. So in terms of TCD, we are called this first hits high intensity transient signal. And that means that we have inside of a cardiac cycle, we have something that's reflected with a higher intensity within the Doppler spectra. So let's have a closer look how this will be presented. And if we look to the transient signal, or what we call transitory signal, then we will see that these are the transient signal of the single blood cells, so the noise level of the blood. And here within we have an increased amplitude, and it's short term, and the amplitude is higher, and it's very visible against the surrounding blood cells. If we stretch out a little bit the time scale of this event, then we can see that here are the variations of the blood cells. It's oscillating, and this is oscillating as well because it's also moving within the bloodstream. So everything that's moving gives us this oscillating pattern, but the amplitude is much higher. And if we look at the duration of the event, then we can see that the duration is short duration. So here in the what we call the magnifying window of the QL software, we will see this event with in red and in green. So that means these are 2 different calculation methods to look at the same event, the same issue here. And this is done with sinus and cosinus, or let's say it's the I and the Q signal. So 2 different calculations to look at the same. And if it's supposed to be an embolus, then we will see similar pattern in red and green signal. So increased intensity signal means if you're looking at the FFT velocity distribution. So usually if you look at the Doppler spectra, that we will see the velocity, the majority of velocity will be color coded, and that means the intensity that's backscattered will given a specific color, and as higher the color, as higher is the intensity that is backscattered to the it's the feedback to the Doppler system. And here, due to this intensity scale, we can see that this is yellow is the highest intensity here. And we see here, this little spot is, yeah, from the color, I would say very yellow. So this will have a really high intensity in comparison to the rest of the Doppler spectra. If we look at the intensity amplitude in a 2D model, then we will see here are the amplitude, the intensity amplitude of these blood cells, the variation of the blood cells. And then within here is the amplitude of this event. If we would be able to see it in 3D, then it would appear here. In the Doppler system, this is not visible. It's just for you to visualize how this will appear within the FFT. So looking here, you will see a cardiac cycle. So here is the end diastolic. And then here you will see the systolic upstroke. Here would be the systolic peak. And then here again, the end diastolic relaxation line. So this is supposed to be a cardiac cycle. And then you see here the end amplitude, the intensity amplitude of the blood cells. And they are looking like little smooth hills. I would compare that with the smooth hills of the Black Forest here in my area. And then within, we will face this Mount Everest within these smooth hills. So this is the amplitude in comparison to the surrounding blood cells of the event. So what exactly is an embolus? How will we describe the nature of an embolus? Well, an embolus is a particle. It can be gaseous, it can be solid, it can be heterogeneous tissue, but it has a higher reflection than the single blood cells, the surrounding blood cells, but it goes together with the blood cells in the bloodstream. So it has the same blood flow direction as the blood cells. Has a higher intensity. And it only can be visualized within the Doppler spectra, means it has to be inside of a Doppler spectra because it goes as all other blood cells within the bloodstream. And very characteristic is that it has a typical sound that we can easily identify it by listening to it. So already in 1995, there was an international consensus committee, and they pulled together the so-called identification criteria for emboli detection. And these criteria also are included in the algorithm, emboli detection algorithm. So they are described as follow. It's a short-term event. It's less than 0.1 second, or let's say less than 100 millisecond. And it shouldn't be higher than 60 decibel transient signal. It is supposed to be unidirectional in the spectra, means it goes in the same blood flow direction as the blood cells that we are looking on. It has to occur randomly in a cardiac cycle, in one Doppler spectra, in one heartbeat cycle. And since it's going with the same speed like the blood cells, because it's also depending on the heartbeat, so it will not change frequency within the Doppler spectrum. And again, it has a typical acoustic sound. In comparison now, how will we differentiate an embolus signal from an artifact? So what is an artifact? So basically an artifact is an impaction of the Doppler beam, mechanical impaction by shaking, tapping the probe, or patient movement. And therefore, the artifact will appear very often at the same time in both blood flows direction towards the probe, away from the probe, but also possible depending on the way, if the fixation probably is shaking or so, that it will appear at the same time on the right and the left channel. So looking at our software, then we will detect events or hits. And then the software is differentiating between real embolus and artifacts. When we look at the emboli detection module of the QL software, we will have here the user interface of monitoring. We have the right channel, we have left channel, we have here the Doppler parameters, we have our indices. And in the indices, if the emboli detection is switched on, we will also see here another indice field, and it gives us the number of events that has been counted. And then the events here in the list appears as embolis. So an embolus here will be here shown as an event. If we look at the histogram, then we will see here the events means the embolis displayed in green and the artifacts in gray. In the Doppler spectra, here the red spot that can appear here. And here you see here's the yellow line that represents the embolus, which is then listed here in the event list. And it gives us the time stamp, and it gives us the noise level, which is recorded, means the transient signal. Sometimes it can happen that people see in the Doppler spectra the red spot, but it will not appear in the list. So therefore, please check carefully the threshold level, the set threshold level. So in this case here, the standard is set to 9 decibel. And if an event clearly shown as an embolus, like here, will not appear here, then it means that it's below the threshold level. So here the threshold gives us the threshold for all the automatic detected embolis with a noise level above 9 decibel. That can be changed and modified in the options. On options. So why should we do emboli detection? Well, basically, there are many reasons why to do emboli detection. First of all, an embolus can cause stroke, and stroke isn't good for people. You know, that will impact very hard the situation of a patient, so brain tissue will be damaged. This will affect the rest of the body functionality, and so the patient will suffer after a stroke, most probably from lifelong restrictions. So it can be used to look for risk factors, especially if during surgery, and if during cardiac surgery or vascular surgery, if doctor can see that there are a lot of embolis appearing during operation, then they are aware that this patient probably may suffer from stroke after this kind of operation. If doctors do emboli detection and see still embolis, if they have already suffered from stroke, so that means that they probably will have a higher risk to get a second insult. And then also monitoring with emboli detection can be also used as to see for therapeutic effects. So if, for instance, you have done a carotid and arterectomy, that you can face later on if there are still a source of emboli, means automatically source of embolis. Embolis are always increased risk for stroke. And then also emboli detection can be used for patient foramen ovale, means this right-left shunt. And actually, since the last 30 years, TCD has been used, and together with emboli detection has been used to look for the right-left shunt. And there are many, many more good reasons why we should do emboli detection. And actually, nowadays, it becomes more and more of importance. So doctors are more and more aware that the benefits of doing emboli detection to patients will give them extremely good information for stroke diagnosis, for stroke prevention, and also to look for therapeutic interventions. As you may know, or being aware of, DWL not only offers automatic emboli detection, there's also a second module from where detected embolies can be differentiated between solid and gaseous embolism. So this is a specific module, and it also has specific hardware because the algorithm behind is using a so-called multi-frequency probe. So normally emboli detection is done with the 2 megahertz, which is the normal standard frequency to insonate the temporal window, to looking for the circle of Willis, and especially to look for the MCA, because this became the standard segment to do monitoring. And with the emboli differentiation, we are using the multi-frequency probe, which looks at the event at the same time with 2 megahertz frequency, and in addition at the same time with 2.5 megahertz frequency. The reason why 2 and 2.5 megahertz is used to differentiate between solid and bubbles is that the founders of this algorithm, which are Dr. Russell from Oslo and Professor Brucher here from Germany, they found out that if an embolus, solid or bubble, is measured with a 2, that there is not a big change in the behavior of backscattering ultrasound. But by measured with 2.5, there will be a big difference. So using this fact was allowing them to differentiate between solid and air bubble. If you want to get more about the algorithm of the multi-frequency insonation of the differentiation, then you can have the article of the validation article of this paper. So in this article, they state that the sensitivity, the automatic detection to differentiate between artifact and embolus is extremely high. And actually that has been proven by many papers as well, that the differentiation between embolus and artifact is very sensitive. In comparison, the differentiation between solid and gaseous is not as high. So there is about 80% reliability for do this differentiation. So the question is always, so why should we differentiate if it's not 100% reliable? Well, even if it's not 100%, but it will still give a lot of useful information in specific application cases. So let's go back again to surgery cases, for instance, open heart surgery. So in that case, we have 2 sources of embolies. We can have gaseous embolies caused by the on-pump situation if the patient is on a heart-lung machine during operation. And at the second time, solid particles can be created by the operation technique itself. So this will help very specifically where the operation technique has to be improved. And also that will have also let's say preview on the outcome of the patient after the operation. So have now a look on the module itself. And you see that it looks not very different from the normal emboli detection module, even if you have to switch on here and then using the multi-frequency probe. So the user interface is very similar. Also, the magnifying glass is very similar, but in the indice list, you see that here it's not only telling you about events, it's telling you the numbers of counted solid ones and counted gaseous ones. And also here in the event list, you can see that here we have artifacts, we had the numbers of gaseous and solid particles. If you look at the histogram, we can see that the gaseous ones are here displayed in light blue, and that the solid ones are displayed in kind of purple color. So as mentioned before, there are many good reasons also to differentiate, to look for the differentiation between solid and gaseous embolism, and that will lead to quality control during surgery, a specific cardiothoracic surgery or cerebral aneurysm surgery. And it can be also used for diagnostic and treatment in post-operative monitoring procedures, and also for pre- and post-stroke evaluations. So before I continue with the PFO, I would like to show you some examples of emboli detection within the software. So wait. So we have here an embolus record. And you see here our Doppler spectra. We have the left MCA, we have the right MCA, we have the M mode, we have the trend window, and we have here, we have the event list, where we can find all the events with the timestamp. And also we can see in which channel it was recorded. What you also can see here is that the gain setting of the Doppler spectra itself is quite high. And so that means that if we have microembolism, that probably that we cannot view it very good within the Doppler spectra. I have an example here. So have a closer look on this one. Can you see that there are two real emboli in this Doppler spectra just by looking on it? It's hard, yeah? So if we click here, so this is the line that shows you the selected embolus here with the timestamp. It's in channel 2. And you can see here, there is the embolus. It's not so good seen. So the recommendation to do emboli detection is always to reduce gain setting and probably also power setting to make the blood cells, means the normal Doppler spectra, more shiny. And in this case, we will have a better view if an embolus, a microemboli with a low detection level will appear here. So here same for here. Really tiny microembolism only with 11 decibel. And within this Doppler spectra, it's extremely hard to see. So let's see if we can find an example where it is better. Okay, here we have a record, a patient record. And we can see here in the left that they have done the setting of the Doppler spectra a little bit too low, probably. Well, in case of emboli detection, it doesn't matter. You see that the embolus here is shown extremely nicely, so we can really see the embolus. And also here in the M mode, we can see that it's moving through the depth. Oh, by the way, this is another thing that you should be aware, if especially the people who have already experience with the old software, emboli detection software many years ago. So at the beginning of emboli detection, there was also identification criteria that there should be a time difference to make sure that an embolus is traveling, because an artifact does not travel, but an embolus is traveling with the bloodstream. So in old emboli detection user interfaces, there have been 2 sample volumes within a segment. So if an embolus was recorded with a time difference in the second sample volume, then that was one criteria to be fulfilled to be a correct emboli. Nowadays, we are using the M mode, so we can see an embolus moving through the M mode. And here in this very nice example, you can see that in normal cases, if there is no embolus, the intensity, or let's say the gain, is set so low that the M mode is not really visible. It's really too shiny. But in case of an embolus is appearing because of the increased intensity, what you can see is that here you can clearly see that there is a movement from depth to superficial, because it's in the MCA. So you can see here, so this is superficial, this is deep, and you can see that this event here moves through the depth along the MCA. Very clearly to see. So general rule, increase when you set up the MCA Doppler spectra. Also adjust the gain in a way that the Doppler spectra is more shiny. So reduce gain. And dependent on if you also need to have correct calculated indices, then you have to make a compromise. Reduce gain, but in a way that the envelope is still set correctly. So here you see that there is corruption, means that the automatic algorithm to calculate the indices will not give correct indices display, because the gain is set too low, so that the envelope does not follow correctly the systolic and diastolic line. But embolies can be seen extremely well. Here on the other side, you can see that here the compromise is well done. That means if here an embolus will appear, that we have the embolus, we can see it much better than in the previous record that I have shown you. But also here we can see that because of the correct setting of the envelope, that we can also believe that the measurements, the velocity measurements, are correctly done. So that, in my opinion, would be a really good spectra setting to do emboli detection in case that the velocity measurement needs to be accurate. This is perfect if you're just looking for micro embolism. Then it doesn't matter if that the envelope will not be covering the Doppler spectra quite nicely. Now let's have a look on the magnifying. So how can we make sure that this event is indeed an embolus and not an artifact? So therefore, we can have a look on the magnifying glass. Let's first. Okay, so this is our embolus. And first we see the yellow line. So that means here in the list highlighted, this is the embolus is represented here. We see this is in the first channel. And it gives us the information that it is detected with a transient signal of 16.7 decibel. in the Doppler spectra. And here on the other side, so we have the yellow line also always on both sides to see if something is appearing at the same time in both channels. So here it's not in both channels, it's only in this channel. It's inside of a cardiac cycle. That's clearly to see, even if it's shiny. You can see it's inside of a cardiac cycle. And it's only within blood flow direction. So it's in the MCA, means it's towards the probe, and it's not in the other blood flow direction here below the zero line, which would mean that it is away from the probe. So here, all criteria are fulfilled to be a correct counted emboli. In the magnifying glass, we can have different views also. So we see, yes, there is a movement. So it's moving through the M mode from depth to superficial, because MCL goes from inside to outside towards the probe. So we have the correct movement here displayed. And if we click with the right mouse, so we can look at the spectrogram view. So we see here the background noise of the blood cells, and we see indeed that there's an increased red spot within the Doppler spectra. Okay, perfect. Looks like a correct identified embolus. Then also we can have a look on the raw data, which is the transient signal, and we see here, this is the red, and the green means I and Q signal, and we see that first, it's having the typical spindular waveform, it's oscillating. Both are almost identical. It's a short term, so if I'm setting here markers, you see it's less than 100 milliseconds, so the duration is also very short. And it's increased compared to the background noise, to the blood cells. So all of this is telling me that this embolus was correctly identified. So let's see if we find a typical artifact. So this is supposed to be an artifact. Oh no, this is not, it's as an artifact, but here we can see it is an embolus. No, it's not. This is the embolus. So the artifact here is this. It's on the right side of the line. So this one. And this also goes to this one, which is this one. So here it's correctly identified. And if we have a look, then we can see this is the embolus. And this is something within here, a variation. For any reason, maybe it was this one that this looks like a spindular waveform, but you can see it's not identical with the green signal. So this is looking at this little dot, so correctly identified as an artifact. Let's see what else we have. Ah, yeah, nice artifact. Here you can see that we have an artifact which is at the same time above and below the zero line, means in both blood flow directions. It's not in the second channel, okay, but you see that's at the same time above and below the zero line. In the M mode also you can see that this is not a movement, but this is something that appears at the same time in both blood flow direction. If we look to the magnifying, we see that's up and down, and the duration is above 100 milliseconds, which is typical for an artifact that usually they are higher, the duration is longer than 100 milliseconds, sometimes 200 to 300 milliseconds in comparison. And it's not really identical, it's just the up and down. Let's have a look on the spectrogram. Here you see it's a long It's very long. It's too long to be a short-term event, and it's above and below the zero line at the same time. Correctly identified. So here we have also an artifact which is above and below the zero line. And if we look for the magnifying, we also can see it goes up and down and up and down. And you see this is also very long. You see here it goes from here to here. And in the green, it's from here to here. So it's not identical. It should be identical to be a real embolus. So let's assume another case that there was an artifact, that there's an artifact. Let's say this would be a real embolus, but the software was counting it as an artifact. In this case, you can re-evaluate and call it an embolus. What's happening here is, oh, not here because it's in the first channel. Here, it will automatically increase the number. So let's change it back to artifact. So if you rename it to an artifact, then it will give a lower number back. So this will be always updated. If you change, if you change from artifact to emboli and the other way around, that you will increase and decrease the number here in accordance. So what is the reason that in the list that we can find artifacts that they are embolized? And probably we can find embolies, but if we are having a closer look on all the identification criteria, then that appears to be an artifact. And this has to do with the algorithm that we have to look at the different identification criteria. So let me go back to my PowerPoint presentation. And let's go back to here, to the identification criteria here. So the algorithm is just an algorithm. It's not a human observer. And the algorithm is checking, is this event short-term? Yes or no? Is it unidirectional in a spectra? Yes or no? Is it randomly in a cardiac cycle? Yes and no. Does it change frequency within Doppler spectrum? Yes or no? Is it audible? Is the sound audible? Yes or no? So in this case, at the end, is checking, the algorithm is checking how many criteria fulfilled to be an embolus. And if there is a majority pointing on an embolus, it will be marked as an embolus. And if the majority does not show that's supposed to be an embolus, it will be as an artifact. So for instance, let's say there is an event and only 2 points are fulfilled to be an embolus and 3 are fulfilled not to be an embolus, then in this, it will be counted as an artifact. But if the observer goes through again, then he can rechange it. And because a human observer will still be able to do the correct identification. So then it can be correctly counted by manual reviewing. So some people, in my experience, say, but if I have so many events, like for instance in a PFO, well, also here, sometimes it's not really necessary to know the exact numbers. if you have a massive shower of emboli, well, even if some of them are not correct identified as emboli, if you have a shower, you know it's critical. If you have, for instance, an emboli record, let's say a preoperative examination, that you have a patient with a carotid stenosis, and you would like to see if you have a source, if this is a source of emboli, let's say if the patient is flowing emboli, then in this case, each embolus counts. But usually in a count like this, within an hour, as it's done for an hour, you will not find so many emboli. So if you have only 5 or 6 emboli within an hour, so that's pretty fast to go through and make sure that each of the embolus is correctly identified. Okay, so that has been the information and tips and tricks for emboli detection. And now I would like to show you the benefits of the PFO standardized examination procedure, which is still unique to DWL. And PFO is done since I know. I started at the beginning of 90s in hospital in neurology, and we have already done PFO testing there, but do it to the limited technique that we had almost 30 years ago. It was quite simple, the test. So we had no continuous record. We had no specific emboli detection module. We simply had our normal Doppler spectra, and we had the thermal printer. And in case when we started to do the examination for PFO, at the moment that the doctor was injecting the bubble mixture, we let the thermal printer run, and so we have only the documentation on a little piece of paper. So that should have been enough. So TCD is still developing, is continuously developing and still developing today, but already in 1999, the Consensus Conference of the Neurosonology Society in Venice was stating a consensus of how to do a standardized PFO procedure. And even if that is also 20 years ago, there have never been software which was fulfilling all criteria based on this consensus. So starting DWL, now starting with the software QL version 3.6, now offers you a whole test procedures in accordance to the consensus committee from 1999. For those people who are quite new to TCD and do not have so many information about the clinical background, I would love to start with the explanation, what is a PFO? A PFO is a hole in the heart, in the atrium, in the right and the left atrium, which is like a bypass. And that means if this hole here is open, if there is this hole open, that means that in the arterial blood circulation, and this is the venous blood circulation. So this is oxygen-rich blood, this is oxygen-low blood. And so first of all, we have a constant mixture of oxygen-rich blood and oxygen-poor blood. And that means that this person is constantly under-supported with oxygen because of this exchange. And that means that this person will be probably suffer with energy lacks and difficult situation because of their under supportment of oxygen. And the second issue that will appear or can appear here if we have this hole in the heart is that we have a source of embolies. Normally, in a closed arterial circulation system, we will not find anything else than the single blood cells and what belongs to a blood circulation system. And embolies usually are not founded here, not found in the arterial system. For a healthy person, but it's normal to have embolies. For all of us, it's normal to carry out embolies in the venous system. But as long as they stay in the venous system, it does not harm us. But if we have a hole in the heart here, then it may travel from the venous system to the arterial system, and then with the heartbeat probably goes up to one little artery, which then will be blocked. And depending on where this artery is located, if it's in the brain, it's a stroke. If it's in the heart, it will be a heart attack. If it's in the lung, it will be a thromb, emboli. So depending on that, we will, or this person will suffer from defects. And this can be easily found with TCD. So what is the reason that we have this hole in this heart? So this had something to do with pregnancy. So if the baby is still in the mother's belly, the baby does not need to breathe and cannot breathe. So it gets all the support, the oxygen, as well as the nutrition through mother's blood. And so the lungs are not connected to the blood system till it is born, till the baby is born. And therefore, because the lung is not connected inside of the pregnancy, so there is this hole in the heart. So this can circulate inside of the baby without using the lung. And then after birth, when the lung starts the functionality, normally this hole will close. But unfortunately, it was found that for 1/3 of all people worldwide, this hole will not close or will only close incomplete. And so people who suffer with PFO are at a high risk of stroke. So the PFO test is used to detect the PFO, and that can be done by injecting a so-called bubble mixture, gaseous bubble, to the venous system. And if there is the hole, if this hole is open, that means that it will cross over to the vein, to the arterial system, and then can be detected in the MCA. So sometimes it may happen if they do the PFO test and they do the first test and they do the injection, that there will be no bubbles appearing at the first test. Maybe the hole is not big enough. So in this case, there's a second test required with a so-called Valsalva maneuver, and that makes the bubbles moving under pressure from one side to the other side. So a Valsalva maneuver means that there is an increased pressure on the chest, and during the test, the person or the patient is be called to hold breath and then to push into the breath like. So this makes a lot of pressure, and then so in this case the bubbles can be pushed over from venous system to arterial system, and then in the second run, very often if there is a small PFO, then we can still see bubbles appearing in the MCA. This also explains why in typical daily situations this will make problems to people. So what is a natural Valsalva maneuver in daily praxis? Well, everybody needs to go to the CVWC, and if we sit there and sometimes we have a hard time, you can make a lot of pressure to your chest by sitting and pushing. So that's one typical situation where this can happen here. And then also you may have heard that women during labor will afterwards suffering from stroke. And so because of the pressure that appears during labor, that a lot of embolies from the venous system can be pushed over to the arterial system, and then that as a late result from birth, then that these women will suffer with stroke because of that. So that's another typical situation when this can appear. During my clinic time in Germany, I was working in a hospital in Munich, and that was right next to a football club, a very famous football club. And one day, one of the football player, he was on the field, he was just falling down, and he was unconscious. And he came to our hospital because it was the next hospital to the training place, and they found with him this PFO. So that was the consequence of during the play when he was working hard and when the whole system is up on energy. So that was another situation that this could happen. So for sports people, that will also be an indication to look for PFO if they are suffering. So some facts about PFO. So what do we know about them? So PFO appears at approximately 26% of all adults. PFO is diagnosed in 50 to 70% of patients with stroke of unknown cases. So that means some people carrying out a stroke and doctors do not know what is the reason for. So that would be an indication to look, maybe this patient could have a PFO. Then also, if a person had a stroke and then probably later carrying out a second stroke, that could be a reason because they is having a PFO. And well, if this hole is still open, that means that there is always a risk to have another stroke again. Okay. So, and also if people have different risk factors, like with migraine, headache, arterial septal aneurysm, things like that, and there is a PFO, that will lead to increased risk of stroke. So what are the options for people when we do a PFO test and we find PFO positive, means that there is a hole in the heart? So what are the options for these patients? Well, first, if we do nothing, that means they always will have an increased risk of carrying out a stroke. Or if they had already a stroke, that the possibility to get another stroke is quite high. They can get a lifelong therapy with anticoagulation or aspirin or some drug medical therapy, but that would be lifelong. And as we know, medication can be sometimes helpful, but also at the same time can be not so good for health because of the it's unnatural. Let's say it's unnatural, so that will also have some side effects probably. And then they can do closure of the PFO, and the closure can be by traditional open heart surgery, or can do some other kind of closure procedures like robotic surgery, minimal invasive, or doing an umbrella, something like this, or transcatheter closure of the PFO. So these are different possibilities, and therefore it's good to know. It's good to know, is there a PFO, and is it a big PFO or a small PFO? That also will have an effect. Of course, as bigger the hole, as higher is the risk to carry out the stroke or get more strokes. TCD versus TEE, transesophageal examination. So what is the benefit? Historically, TEE was supposed to be the golden standard, but it's not so accepted among the patient because you have to swallow a probe, so it's uncomfortable, and also it can hit the esophageal trunk, so it's invasive, whereas TCD is non-invasive, it's safe, and in comparison is cheap, and it gives really accurate and reliable information, and therefore TCD was becoming a really good tool to diagnose PFO among patients. I think it's more reliable to use TCD because of the acceptance. So PFO testing is a sub-program of the Embolidetection. And if you want to do a PFO test, and if you have done it in the past, then of course you have opened monitoring and especially the Embolidetection. So you have got, as you have just seen in the previous presentation, you have the Doppler spectra from both sides, bilateral. You have the M mode to see if there is a movement of the event. You see the increased spot, and you have the numbers of hits that appearing, and that's important to diagnose the grade of PFO. So that's all that you had before. And then together with the consensus, how to perform a PFO test in order to be repeatable and comparable. So due to the consensus, the patient should be in a supine position. You should do bilateral monitoring. You need to inject bubble mixture. And if necessary, it should be repeated with a Valsalva maneuver. And that's important. That's needed if the first test on the basal condition was negative, means if they have been at the first try, if there have been no bubbles appearing. The second injection starts 5 seconds before Valsalva. That means the doctor is injecting the bubble mixture, waiting for 5 seconds before the patient have to increase the pressure of the chest. And then the patient should hold the Valsalva for 5 seconds before he release it again. And so the overall maneuver of the Valsalva maneuver should be about 10 seconds. Afterwards, we are looking at an embolus number. And based on the numbers of embolies, the graduation or the scoring can be done. So also what it should be recorded, and which so far hasn't been possible within a traditional software, that we also should be aware about the embolus latency. So we need not only the emboli number to be recorded, we also need to record the embolus latency. And both should be documented, and it should be separately documented for the basal condition and also for the Valsalva maneuver. Again, a good setup of the monitoring fixation is half of the rent doing Embolidetection. So it's quite important to have the correct setting, to identify the best temporal window, to find a stable signal for the MCA. And then the patient should be in a supine position. Then they need a needle into the cubital vein. And then also add a 3-way stopcock in order to create the bubble mixture. Then when they do an inject, we insunate the MCA here. And if And if the bubbles are crossing over from the venous system to the arterial system, it will come up through the carotid artery, and then it will go through the MCA branch and will be detected by the Doppler probe. And then we will see here in this example, this is what we call an embolus shower or a curtain. And you can see the massive shower of emboli here within the Doppler spectra, and here the movement in the M mode. So again, here our Doppler spectra. Here are the events, like in the normal emboli detection software, the number of emboli that has been automatically recorded. And the question is, what is an embolus latency? So an embolus latency is the time, the travel time of the embolus from starting from injection to the first embolus is appearing in the Doppler spectra. So this is the embolus latency. And there are some norm values that was evaluated in some papers. And they say the injection and basal condition, the latency time is approximately 9.7. And for the Valsalva maneuver, because of the pushing, so it's a little bit higher, it's a bit faster. So that's approximately around 7 seconds. So we have set up our monitoring fixation, and fortunately you have seen that in the previous presentation 2 weeks ago. What are the possibilities, which system to use best in which application, and how to fix it in the correct way. And let's assume we have done it correctly for both channels, and we have a good and stable Doppler signal for right and left MCA. And if we are ready to start now for the examination, we can press here in the ribbon tab monitor, and we can press PFO. And if we press so, it will open up another window. And this window enables us to do the PFO testing in accordance to the consensus committee. So you can see here different buttons. So we can start. We can do a marker for the injection. We can do the marker for injection and Valsalva. So this is basal condition. This is Valsalva maneuver. And all tests will be then listed here in this field. So even if a normal test procedure is telling to do one test, a basal condition means the injection, the first injection, and then the second with Valsalva. If for any reason one of these tests needs to be repeated, or one test needs to be repeated several times, all of this will be recorded and appearing here in this window. If you look down here, you have some additional options that goes along to different literatures. So in the literature, we have leading paper from Zanetti and Klingelhofer, and due to their paper, they say that from which point on we should count emboli. And they mean, if you go with these papers, if you look in accordance to this paper, they are saying that they need to count from the first occurrence. That means the count of emboli is done from here. So from here, there is a time window, and from here it starts a time window. And also the paper says that the time window should be about 25 seconds. So that means from here on, for 25 seconds, all the events are counted. Droste and Ringelstein, for instance, and also the consensus conference, they are saying the emboli should be counted from injection. That means from that moment when the doctor is inserting the bubble mixture. And then for the next 25 seconds, all embolies will be recorded. That means here in the first option, the count starts here with 25. Probably that would be like here. So in this time window, all the embolies are counted. But if we count from here, from the first, and after here 9 seconds, we start with the count, or the first embolus is appearing. That means that only, since the time window is 25, then minus 10, so only 15 seconds to count emboli. So the window or the time that bubbles will be counted is shorter than in the second one. And this is something that's doctor opinion, if they go with this literature or with that literature. So that's completely up to the local department and the local TCD school. So in which direction they are going. But the software here in DWL gives the option to do both. And also you can see that the time frame can be changed. Well, the literature is suggesting 25 seconds, but this can be changed. Maybe some sites decide to do research or they have different experience, so this can be enlarged and shortened. If you look on the options in this window, you can see here a second option and it says acoustic signal. And if you check this, that means that during Valsalva maneuver, you get an acoustic output. Here it says 10. Remember, from the consensus committee, they say the all-over maneuver should be 10 seconds. And so to make it easier to be within this 10 seconds time limit, you can educate the patient that when he's doing Valsalva, that you can tell him, if you hear this noise or this sound, then you can stop with the Valsalva maneuver. So that's much more accurate than if a person has to look on the watch and saying, stop now. So here, to make it accurate, you can give an acoustic signal for the patient to stop with the Valsalva maneuver. And also, this is changeable because it may happen that doctors decide to have a longer period or shorter period, or based on new research, wanted to change this. The way to create the bubble mixture is nowadays standard to use a syringe with 9 cc of saline and 1 cc of air. And then together with a 3-way stopcock and a second syringe to mix it forwards and backwards to create this kind of bubble mixture, which then will be injected to the vein. And then we have the contrast agent to see if there is a crossover or not. In the very past, let's say when I started in the hospital, there was a chemical drug that was from the industry, but this is forbidden now. So nowadays, standard is really that everybody is using their own self-created bubble mixture. So it's quite of importance also for the doctors to know exactly how to mix it and to make sure that you get a kind of stable bubbles inside of this mixture in order to have a good result in finding PFO. So we have the patient position, we have the setup, we have the run, we have clicked on the PFO, we got the window. And now when we want to start recording, means till this moment, it's only online, but it's not recording. But if we want to start with the recording, then we say start PFO test. If we press this button, that means that from now on, we record the examination. So still meaning that the doctor can create the bubble mixture, and then by the moment that he is starting the injection, we press injection. So if we press injection, a marker will be set into the Doppler spectra and also to the event list, so that we know at which time stamp we have started with the injection. And you see that here the injection will be automatically appearing in the list. And then we got the latency, means is at the moment that the first embolus is recorded from the probe, that from that moment, then the latency will be displayed here, and then the count starts for the set time window. In our example here with 25 seconds, this is the preset, this is the standard due to literature. And so here in this example, we have an embolus latency of about 6 seconds, and we have here 3 emboli counted. We can repeat this kind of basal injection as often we want, and they will be all listed here with the number of emboli and with the latency that was recorded. And if doctor decides to continue the test with Valsalva maneuver, then they repeat the bubble mixture, and by the time that they start injection, you press the second button which says injection and Valsalva, and then a second marker will be set to the Doppler spectra, but also to the event list with the timestamp. And then you will get the emboli count and the latency in accordance. If you completely finish with the test, you can say stop PFO. So you see this is the toggle button, and if you press on it, it will start, and then it changes to stop, and that means if you press on it, it will stop. So start and stop at the same button, then injection for basal condition and injection plus Valsalva to do the Valsalva maneuver and to record and document it. When the test is finished, now the doctors can use graduation scales, tables, depending on which literature they follow. So the consensus conference of the neurosonology, they are using a so-called 4-level categorization, and due to their categorization, they grade the PFO. For grade 1 would be negative, meaning that if there is no bubble, even after the Valsalva, then there is no PFO. Grade 2 would be if 1 to 10 bubbles are there. Grade 2 would be if we have more than 10 bubbles, but no shower or no curtain. And grade 4 means that's a really big PFO. Then we will have a shower of micro bubbles, or called a curtain. In the US, people very often use the Spencer grading scale. And here you see the grade is from 0 to 5. And also it looks at the number of counted emboli to grade the PFO. Again, this is an example how a curtain or a shower of emboli is looking like. And at the very, very end, after you have recorded, after you have done the evaluation and you have graded, you have to the documentation and the reporting. And the report is done in the typical DWL way, that you recall the file from database, and then you open report setup. And by the end, you find another option, says PFO test. And if you make sure that you have checked this and open report, then at the end of all other that you can include into the report, like the spectra, like the number of emboli, events, the histogram, whatever, that you get by the end. You get also the information about the injection, the latency, and the embolus number. And if you have done bilateral examination, you will get the bilateral information. So I'm proud to say that DW is still the only company, TCD company, that offers the full standardized test procedure in accordance to the consensus. And so I hope this information have been very useful for you. But before I stop my presentation, I would love also to give you a demonstration on the Doppler software. So let's close this and open the software. So one moment, I need to wait till my Doppler box is starting. You know, Doppler box, the first two LEDs have to shine green, and then I can open my software icon. Okay, I'm double clicking. Here is my software, and I go to monitoring. And I first look for my patient. So let's say the patient is already in, and I'm starting a new examination. And I go online. Oh, now let me restart the software. One moment. Okay, here with the new start, I'm in routine. So for those who need to set up the emboli detection from the very beginning, so we go to view, we say monitoring, we can add emboli detection, we can add a trend window, we can do bilateral. In this case, since I'm here by myself, not able to pick one of you as a victim, as a guinea pig, and doing a live demonstration, I have to do it by myself and just trying to show you the principle. So we have now the monitoring emboli detection and opening database, selecting the patient, and start a new recording. We go online. We are making sure that we're finding the MCA, that we get a stable signal. We set the parameters. Don't forget, well, maybe I can show it. So don't forget to set the gain and the power in the way that we have a shiny signal. Here I will reduce power and gain too much. Probably like this. This is also for the emboli detection. One more thing that I probably need to show you, if you need to change the threshold, that can be done under options, emboli. Here you can change threshold. And that means here, in this case now, above the threshold of 12, the events will be recorded then. Okay, this is all done. And we can continue with online. And at the moment we are ready to start, means if the doctor wants to start with the PFO, We first start the record by pressing here PFO. So here, this window is opening. We start PFO test. Now it's recording. Then doctor starts with injection. And now we have the first embolus appeared and we have the latency, and now we need to wait how many more embolus are coming within the time window. So that would be the basal, and then the doctor can repeat that many times. So we have now the second one. Now he's deciding, or she's deciding, to continue with injection and Valsalva, preparing the bubble mixer again, starting with the injection, instructing the patient after 5 seconds to make a Valsalva. If we have set acoustic noise, after all over of 10 seconds, we will hear an acoustic signal. And that means that the patient can release. And if doctor is happy, we can stop PFO test. Simple as it is. Now we can open. We look at our session. We see this is the record. I open it. I look at the quality of my examination. I see here start injection. I see Valsalva maneuver. So I can review all of what I need to see. And then I'm creating my report. I selecting to my monitoring report whatever I need and want, or deselected. Don't want a histogram, but I need the PFO information. I say create a report. And finally, I got my PFO report also in accordance to the consensus committee. Okay, well, I hope you enjoyed this presentation as well. Yeah, it was for me a pleasure again to be with you, and I really, really hope that we continue this one day again face to face. I really miss you all a lot. So yeah, fortunately, we will have in 2 weeks, we have another presentation. So I'm looking already forward to see you there. And this will be available soon also in the download center. So you will have the presentation, the PDF, but also you will have the record available for your self-study